In general, that's a principle in oncology. We use the most effective agent as early as possible.
First, we'll set the scene and discuss the historic standard of care. So for metastatic HER2 positive breast cancer, there's been a long-standing historic standard of care, first reported by the Cleopatra trial in 2012, which was taxane with trastuzumab pertuzumab, followed by trastuzumab pertuzumab induction. And this regimen demonstrated really impressive progression-free survival benefits as well as overall survival benefits that persisted with long-term follow-up. So this has really become the standard of care for the past 10 plus years. And this strategy and philosophy of induction therapy with taxane and trastuzumab pertuzumab followed by maintenance with HER2 targeted antibodies has been the sort of operating standard of care. Dr. Bardia, what do you see as the current unmet needs in the first-line setting for metastatic HER2 positive disease?
Absolutely. So we tend to use THP in the first-line setting for patients with HER2 positive disease, but you can run into issues in terms of side effects. Taxanes can increase liver enzymes. You have some patients who have residual neuropathy. And because of that, sometimes we struggle with the chemo portion related to the THP. Brain metastases, that's another big unmet need in this patient population. And then eventually patients have disease progression, and majority of them. So from an unmet need perspective, it is therapy that would have lower toxicity, particularly less neuropathy, could treat or could prevent brain metastases and also improve progression-free survival and overall survival.
That's the type of therapy we need. I've also seen a statistic that up to 30% of patients don't even make it to second-line therapy. How does that impact sort of the gravity of choosing first-line therapy to you?
Absolutely. In general, that's a principle in oncology. We use the most effective agent as early as possible. That's true for HER2 positive disease, for metastatic TNBC as well. Now, you were talking about attrition rate. With every line of therapy, there's a subset of patients who don't get to the next line.
Thank you. Can you now share with us the Destiny Breast 09 study and sort of how that, what the findings were?
Absolutely. So Destiny Breast 09 was designed to look at an antibody drug conjugate called trastuzumab deruxtecan. It's an antibody drug conjugate that binds to HER2 and then has 8 deruxtecan payload molecules attached to it. And the idea is to deliver deruxtecan, which is a very potent TOP1 inhibitor, to cancer cells and thus induce apoptosis and cell death. So in Destiny Breast 09, TDXT was evaluated against THP. The trial had 3 arms. THP was control, TDXT was the second arm, and third arm was TDXT plus pertuzumab. At ASCO 2025, we saw the results of Destiny Breast 09 in the first-line HER2 positive MBC setting.